Okay. Welcome back to uni, everybody. Hope you had a nice break. I'm attached to the lectern today because the lapel mic is flat, so I'll have to stand behind here today. This is just to remind you about the mid-semester test that is due next week, same place, same time. Okay, so please make sure you're on time because we will start at 1:10 and we will finish at 20 minutes to 3. So you can see that it's 90 minutes in total and there will be 80 questions for you to answer. Now this may vary if you are a master's student. Okay, if you're enrolled in M7 New, this may vary. So you can see that the format of the mid-semester test is very similar to what we've been doing throughout the semester. So you will have some multi-choice questions to answer. You will have some short answer questions, so same sort of format that you've had in your prac questions, and also your learning objectives are really good basis for short answer questions as well. And then the case studies will be similar to what we've been doing in the tutes and the lectures. So there should be no surprises for you. Okay, so it's a format that you're very used to. And this is also the same format that will be used in the final theory exam. So again, you will be used to that format by the time you get to the theory exam. Okay? So this is happening in the lecture time next Tuesday. Then in the tutorial time on Wednesday, what we'll do is we will squish into the haematology lab. So hopefully there won't be anybody in the histo lab next door, so we'll be able to grab the chairs and bring them in. And we will have a review of some of the blood films that we've looked at in the semester. Okay? If you've got any particular films that you want me to focus on, perhaps if you could email me, or perhaps even put it up on the week 7 discussion board and say, you know, can you look at the films from the prac in week X or something like that, because we only have 50 minutes there. So, you know, we need to focus on what it is that you're concerned with. So you would have seen that the skills test results, Yik Chang marked those over the break for me, and the results are up there. So remember, it is really a snapshot of where you are at the moment, and perhaps give you a bit of an idea about what you need to improve on. The main issue with a lot of people seems to be time management. Okay, so what I suggest, and I put it in my post on Milo, was that you practice by giving yourself a set time limit each week when you're looking at your blood films. All right, try and see if you can get each of your blood films done and dusted within 15 minutes, and that's really, really good practice for you. Okay. So the prac test will be next week as well in your normal prac time. So I think we're looking at some blood films. I think you will be doing a retic count, and just a few of the normal things that you've been doing during the semester. Again, so again, no surprises for you. Okay. If you've got any questions, please pop them up on the Milo discussion board for week 7, so that everybody can see the answer. Okay. Everybody happy with that? Yes, Dylan.
In terms of content, what is tested?
So the content will be the first 6 weeks. So just for the recording, the content that will be tested is the first 6 weeks of semester. Okay. So this is our final week, and so we're looking at extrinsic hemolytic anemias, as we were last week, but this time we're looking at immune and non-immune causes. Actually, we were looking at intrinsic last week, I think. But we're looking at extrinsic, looking at immune and non-immune causes. The main focus of the hemolytic anemias as a whole really is because I know it's such a large group of disorders, I don't expect you to know a lot of detail about them. I do expect you to know something about their etiology, so something about what causes them, perhaps a little bit about their pathophysiology. Definitely the populations at risk and how we identify them in the laboratory. So the sorts of clinical indicators that tell us whether or not we've got a hemolytic anemia, the sorts of laboratory results that tell us, particularly our diagnostic tests. Okay? So you need to be able to differentiate between them. That's the main thing you need to be able to do. Okay? And then work backwards from there. All right? So you can see here that's what we're focusing on in the lecture today. So I know that you probably haven't had a chance to do, there's a huge amount of preparatory reading, but I've got it up here for two reasons. Number one, if you feel the need to go and read further, this is an indicator of where to go. But number two, just to again remind you about how the course is scaffolded. And by scaffolding I mean that every unit in every year is specifically put there for a reason, and it's so you learn something in that unit that you can then build on in the next unit. Okay? So constantly be looking for those links between the information that you already know that you can then add new information to, because it makes it a lot easier to learn new information if you can relate it to something that you already know. Okay? So I'd like to spend probably 5 or 10 minutes, because I know it's been 2 weeks since you've been learning any haematology, and so just go through and see if you can answer these questions again, talking to the people around you and seeing if you can recall this information. Okay? You're allowed to talk. Okay, how are we going? Do you need more time? Hands up if you need more time. No? Okay. All right, so really this was just to, again, recall information that you already know. So, question 1, hemolytic anemias are differentiated from hypoproliferative anemias in the laboratory by what test? The retic count. Okay, so remember, hypoproliferative anemias, that means when the bone marrow has failed for some reason, and so we get reduced erythropoiesis, whereas with hemolytic anemias, that is a survival defect. Okay, so the cells are not lasting as long in the circulation, and so to compensate for that, the bone marrow activity increases, and we get an increased number of reticulocytes. Yeah? Anybody get that one? Yeah, there's a couple of nods, well done. Okay, so the biochemical tests that differentiate intravascular and extravascular hemolytic anemias are a little bit fuzzy because there is a bit of crossover there with them. So overall, the biochemical tests that can tell us that we've got a hemolytic anemia include things like an increased bilirubin, yeah, particularly unconjugated bilirubin. Yep, lots of nods there, excellent. So the things that differ between the two are with our intravascular hemolytic anemia, we get things like hemoglobinemia, hemoglobinuria, those sorts of things, hemosideриnuria, because of course the hemoglobin is in the plasma, it's in the fluid which is then filtered through the kidneys, so that's why it ends up in the urine. So we also get a markedly reduced haptoglobin concentration in intravascular hemolytic anemia, because remember the role of haptoglobin is to mop up any free hemoglobin that happens to be in the plasma, because hemoglobin is quite a reactive substance and we don't like it left on its own for too long. And so we get markedly reduced haptoglobin concentrations in intravascular hemolysis. So our extravascular hemolysis, so that means it's happening within our reticuloendothelial system, so due to the fixed macrophages mainly in our spleen, but also in the liver and the bone marrow as well. So they are all responsible for extravascular hemolysis, and so again we've got an increase in unconjugated bilirubin. And we've also got things like urine and fecal urobilinogen, which we haven't really touched on. It's mainly to do with the fact that with extravascular hemolysis, because it tends to be more chronic than intravascular hemolysis, you tend to get a more chronic jaundice happening with it. Whereas intravascular hemolysis is nearly always acute, and so jaundice will develop, but it takes 2 or 3 days to develop after the episode has started. Okay? So that's another thing for you to keep in mind. So clinical features that are more common to chronic extravascular hemolytic anemias are things like splenomegaly, they're things like gallstones, because again it is a chronic condition. So you've got this chronic increase in bilirubin, and so of course our gallbladder concentrates our bile, and if you've got a lot of bilirubin there, then you're going to get a lot of bile production, so you tend to get a tendency to gallstones. Also, because a lot of our extravascular hemolytic anemias, the chronic ones, are also inherited, so you tend to get, for example, things like hereditary spherocytosis and those sorts of things. So you tend to see these in children too. And so if we get an increase in hemolytic anemia in children, remember the compensatory mechanism for hemolytic anemia is the bone marrow ramping up production. If this happens in children, what can happen is that we get an increase in the red bone marrow mass in the bones, and so the bones get finer and softer. And so you can actually get bone deformities happening in children. This happens a lot also with beta thalassemia as well. So anything that increases our bone marrow production can also cause bone issues in young children. So with intravascular hemolytic anemia, because that tends to be more acute, then we get a sudden onset of symptoms, and that sudden onset is to do with, you know, feeling ill, feeling suddenly ill. So getting lots of aches and vomiting and fever, and of course red-brown urine. That is often the stage when people will go to see the doctor when they see their red colour in their urine. You can also get indicators of kidney injury with intravascular hemolytic anemia. Kidney injury is very much associated with intravascular hemolytic anemia. So examples of health conditions due to intrinsic defects or erythrocyte membrane defects. So did anyone think of a couple of those? Hereditary spherocytosis, well done. Anything else? Hereditary elliptocytosis, yes. Okay, so there's two there. They're the two main ones. There's a few others as well. And then two examples of health conditions due to enzyme defects within the erythrocytes. Did anyone guess any of those? So we've got G6PD deficiency and pyruvate kinase deficiency. Yeah, they're the two main ones that happen with our enzyme deficiencies. Okay, so how many people remembered some of the answers to those questions? So how many people remembered more than half the answers? So I think, oh, good, excellent. We got a few people with more than half. Well done. But if you remembered some of the answers, or even one or two of the answers, that's going really well, because I know you've had a break in between. So, and that you are also studying 3 other units. So I do understand. Okay, so a little bit more of a review for you. Just reminding you that hemolytic anemias fall under the subcategory of normocytic normochromic anemias, and they are due to a survival defect. So traditionally they are categorised according to the etiology, so according to the cause. So whether it's an intrinsic or intracellular cause, so something that we just talked about with the membrane defect, or an enzyme deficiency within the red cell, or whether or not it's an extrinsic cause or an extracellular cause. And this is very much something that has changed within the environment of the red cell. So the red cell itself might be okay, but something has changed within its environment. And so our intrinsic or intracellular causes are more likely to be inherited, whereas the extrinsic or extracellular causes are more likely to be acquired, again because it's to do with changes in the environment. Okay? The other thing to keep in mind, as we've just been talking about, is whether or not we have intravascular or extravascular hemolysis. The reason why this is important is because this assists us with our clinical conditions and our laboratory tests. Okay, so if we can work out whether it's intravascular or extravascular hemolysis, then that can help us to sort of backtrack to see what sort of a hemolytic anemia it is. So it's just one other tool in our chest to help us to work out what these conditions are. I found this rather lovely table in Keohane, and so there's lots of copies of this in the library for you to have a look at. And what I've done is I've highlighted in red the biochemical results and the haematology results that we have been looking at and relying on as we've been going through looking at our case studies and looking in the pracs as well. So the really interesting thing that I found was that with lactate dehydrogenase, the LDH, is that it is more increased in intravascular hemolysis than it is in extravascular hemolysis, and it's actually, when you get a sudden rise in LDH, that's actually quite a sensitive indicator of intravascular hemolysis. So that's something that you could use in biochemistry, in clinical chemistry perhaps. And the other thing that is a little bit different to the actual table in the book, and that's why I've got it in brackets here, is that according to Keohane, they think that intravascular hemolysis only has the presence of schistocytes, but of course you can get spherocytes in intravascular hemolysis as well. So we tend to get schistocytes and spherocytes, whereas in extravascular hemolysis we tend to just get spherocytes. Okay? Because what's happening with extravascular hemolysis is either the whole cell is being lysed or just a portion of the membrane is being removed by the phagocytes. Okay? And so as soon as a portion of a biconcave disc membrane is removed, it reverts to being a sphere. Okay, so that's why we see spherocytes in extravascular hemolysis. So that table's quite nice. So again, just to remind ourselves of where we are, we've talked about all of the intrinsic hemolytic anemias. So now we're going to be talking in this final presentation about the extrinsic causes of hemolytic anemias. And you can see that they are subdivided into immune and non-immune. So immune meaning that there is some sort of antibody involvement there, and non-immune meaning that it's nothing to do with antibodies, it's some other mechanism. So again, it's looking at the etiology. And this is a list that we've been using, going through, looking at the hemolytic anemias, and so today we're going to focus on the list highlighted in red. We'll start with the immune hemolytic anemias and then we'll go to the non-immune in the second half of the lecture today. Has anyone got any questions? No? All happy? So as we often do, we're going to have a look at a case study as we go along, and you may already know the answer to this case study, and if you do, then as we go along you'll be able to see how the different conditions that we look at might apply to this case study and how we can differentiate the conditions given the information that we have. So this is a 29-year-old female who's been transfused with 4 units of red cells after heavy blood loss during the birth of her second child. To be given 4 units of packed erythrocytes, she must have bled a lot. And of course that's not uncommon in childbirth. So she seemed to be fine, going all very well, but 3 days later she developed a slight fever, complained of abdominal pain and was slightly jaundiced. And so they took a sample of blood from her and sent it down to the laboratory, and this is the results of the blood. So you can see that her white cell count is elevated, her haemoglobin is quite low. It's quite a significant drop in haemoglobin there, particularly when you consider that she's been transfused with 4 units of erythrocytes. Her MCV is slightly high and her platelet count is increased as well. And you can see over on your right here what her peripheral blood film looks like. So just having a look at that blood film, what's this cell here? Just tell the person next to you if you're not sure. Everybody happy that's a nucleated red cell or a late normoblast? And you can see here that the very, very condensed pycnotic nucleus is almost ready to come out. So next time that goes through the spleen, you probably get a macrophage taking out that nucleus. The other thing that is very significant in that image is polychromasia. Everybody happy that there's polychromasia there? Yep. So the nucleated red cell is actually a really good marker in this image, because if you have a look at the colour of the cytoplasm of that nucleated red cell and then have a look in the rest of the field for cells that look around about that colour. Okay, so there are a number of cells that look around about that colour, so they are reticulocytes, and that's what we're talking about when we talk about polychromasia. Okay? So I would say that that's probably 2+ polychromasia there. What are the other features that you see on that blood film? So we've got a nucleated erythrocyte, nucleated red cell, we've also got polychromasia. What else? What sort of anisocytosis in particular do you see there? There's spherocytes there. Everybody happy? Everybody see the spherocytes? I just want to make sure, because sometimes because I see it there, I presume everybody sees it there. Okay? So there's a lot of spherocytes here. There's this big group of spherocytes down here. That one almost looks like it's like a bite cell there. So there's lots of spherocytes here. There's some through here. So that is significant spherocytes. That's probably 4+ spherocytes in that. If the rest of the film was like that, that would be 4+ spherocytes. And that is a significant finding in a blood film. So what's causing this increased MCV, do you think? Anybody got any ideas? Yeah, the reticulocytes have caused it. So you might look at that and say, oh, this is a macrocytic anemia. And yeah, probably if you said on your provisional diagnosis macrocytic anemia, I couldn't mark you wrong because the MCV is 101. I'd probably give you half a mark. If you said macrocytic anemia secondary to a hemolytic process, I'd give you a gold star. Okay, because that is why the reticulocytosis is there. It's due to the fact that we've got some sort of a hemolytic process. Okay, so remember, with your provisional diagnoses, you have to be quite broad in what you say. You can't just jump straight to something, because if you get the wrong something, if you get the wrong definitive diagnosis, then you can't get any marks. Okay, so that's why I always encourage you to be quite broad with your provisional diagnosis. It's a summary of what you're seeing in your results, a summary of the significant results. Okay? All right, so keep this picture in mind and let's head on. Okay, so I think we've related the FBE results. We've had a look at the blood film and we've suggested a provisional diagnosis. So just keep in mind this case study and then think about the further diagnostic tests that might be useful. And remember, you always have to tell me why you've chosen things. Even if you give me the wrong diagnostic test, if you give me a valid reason for doing that test, I can't mark you wrong, can I? So always, when you justifying your choice means giving me a reason for wanting to do that test. Okay? All right, so we'll start off having a look at immune hemolytic anemias. And as you can see here, it's defined as shortened red cell survival mediated through an immune response, especially antibody mediated. Okay? So you can see here that there are 2 broad categories. We've got antibody mediated hemolytic anemias and we've got drug induced hemolytic anemias. So, and then antibody-mediated is subdivided into autoimmune and alloimmune. So just tell the person next to you what's the difference between autoimmune and alloimmune. I'm seeing some beautiful interpretive dance over here. Autoimmune is antibodies to self. Alloimmune is antibodies against other. Yeah? It's really important that you keep that distinction in mind, particularly for next semester when we're talking about blood transfusion, because we talk about alloantibodies and autoantibodies all the time, so you need to get it really fixed hard in your head, the difference between them. In the laboratory, a really, really easy, simple test that you can do to differentiate between autoimmune and alloimmune hemolytic anemias is the direct antiglobulin test, or the Coombs test, the direct Coombs test. So you would have learned about this in any immunology unit that you've done. It's a very easy test, and it's very useful looking at immune and non-immune hemolytic anemia. So you can see here, with autoimmune hemolytic anemias, the direct antiglobulin test is always strongly positive. With the alloimmune hemolytic anemias, it can be variable depending on the blood group that is causing the hemolytic anemia, because it's usually due to either a blood group mismatch. So for some reason the patient had an antibody to an antigen that was present on red cells that were given to that patient. Or HDFN is hemolytic disease of the fetus and newborn. So there could be a mismatch there between the fetus or the neonate and the mother. And so we can have a variable direct antiglobulin test there depending on the blood group of the antibody involved. And again, with drug-induced hemolytic anemia, the direct antiglobulin test result is variable there as well, and it depends on the mechanism, and we'll be having a look at the 4 major mechanisms shortly. So just as a reminder of the principle of the antiglobulin test, or the Coombs test, the function is to detect sensitised red cells, sensitised erythrocytes. So these are erythrocytes that have antibody bound to their surface, or they've got complement bound to their surface, or both. So usually the sensitised red cells that we are detecting, the antibody is of the IgG class. So just tell the person next to you quickly why that is. Why is it that sensitised red cells tend to have IgG antibody on them? And I hope you're telling the person next to you it's because IgG antibodies are small, and so they are not able to bridge the gap between erythrocytes. So they are not able to bridge that natural antagonism between erythrocytes, also known as the zeta potential. Have you heard that term before? No? Okay, you'll learn about that next semester too. So what happens is we end up with erythrocytes that have got antibody attached to them, but not enough to agglutinate the cells. So what we then do to detect these antibodies is we raise an antibody against human antibodies in some non-human species. That's normally rabbits, sometimes sheep are used, sometimes even horses are used. And so what you do is you inject human immunoglobulin into a non-human species. Their immune systems react and produce anti-human antibodies, which is what Coombs reagent is, anti-human globulin. And so we mix the Coombs reagent with the sensitised erythrocytes, and the antibodies in the anti-human globulin bind to the antibodies that are bound to the red cells, and they are able to bridge the gaps then and cause the red cells to agglutinate. And so we see that as positive agglutination in a test tube. Okay? Everyone happy with that? Yep. You will be dreaming about this test next semester. So very much, it's a really easy test to do. So basically you just need to wash excess plasma off a cell sample, put a drop in a tube, add some anti-human globulin to it, give it a mix, spin it down and see if you've got agglutination. So when we're looking at our autoimmune hemolytic anemias now, so these are due to antibodies directed against self. They are subdivided into warm and cold health conditions. So warm autoimmune hemolytic anemias are called that because the antibodies react at 37 degrees. They are usually caused by antibodies of the IgG class, and therefore we usually have extravascular hemolysis with these conditions. Okay? Again, that's because the IgG antibodies are too small to agglutinate the cells, but the sensitised cells are removed by the phagocytes in the spleen. Cold autoantibodies have quite a range, quite a large thermal amplitude. In the laboratory, they react best between 2 and 4 degrees Celsius. In the body, they usually have a thermal amplitude up to about 30 degrees Celsius. And so cold hemagglutinin disease, which is what the conditions caused by cold autoantibodies are known as, are quite an interesting set of conditions, and people who have these conditions usually only have issues in the winter time, because as the blood gets to their peripheries, it cools down to less than 30 degrees, and so the antibodies, which are IgM class, are able to attach to the red cells, and they can agglutinate the red cells. Remember, IgM are what we call complete antibodies, and they can agglutinate the red cells and cause intravascular hemolysis. Or what can happen is that they can attach to the red cells, and then as the blood comes back to the core where it's warmer, they will actually drop off again. And so, but they can leave a little bit of complement behind, and then the phagocytes of the spleen will phagocytose them. So that's why we can also have extravascular hemolysis there as well. We can have primary or secondary causes of warm and cold autoimmune hemolytic anemias. You can see there that primary causes are slightly more common, and they are idiopathic. So that means we don't know what causes them, they just happen. And then we've got secondary causes that are associated with some underlying primary disorder. And so if we're talking about antibody formation, what sort of primary disorders do you think we might find these, the primary disorders that might be responsible for the secondary formation of these autoantibodies? We're talking antibodies. Think about the cells that produce antibodies. Cells that produce antibodies. Lymphocytes. So lymphoproliferative disorders often have an autoimmune element to them, and also conditions where the lymphocytes are being attacked. So bacterial or viral conditions where the lymphocytes themselves are being attacked. One of the most common is glandular fever, because the Epstein-Barr virus actually invades lymphocytes and causes those changes that we see to lymphocytes. And so it's not uncommon to see people with glandular fever with a very mild anemia. And when you actually have a look on the blood film, and I don't know if you've noticed this with any of the glandular fever blood films we've looked at, but you can actually see red cell agglutinates there on the blood film. And so that's caused by an autoanti-big I, which is stimulated due to the viral infection, and then when the viral infection resolves, the titer of the autoanti-big I drops away to nothing. And so that's a very common secondary cause of cold autoimmune hemolytic anemia. So then we have a look at the alloimmune hemolytic anemias, and these are usually due to some sort of a blood group mismatch. So it can be either due to blood being transfused, where there is a mismatch between the transfused blood and the recipient, or hemolytic disease of the fetus or newborn can also be caused via a blood group mismatch between the fetus and the mother. And so we find that if we get an ABO blood group mismatch, and it's to do with blood transfusion, that can be quite a catastrophic result that can result in the death of the patient. And the reason for that is because we already have antibodies to the blood group antigens that our blood cells lack. So I am group O RHD positive, so even though I've never had a blood transfusion, I have anti-A and anti-B antibodies in my plasma. And so if I was given blood group A, blood group B, blood group AB, they would immediately lyse as they hit my plasma, my blood. Okay, and so that's why we have what we call immediate intravascular hemolytic transfusion reactions, and they can be quite catastrophic. So the other form of blood group mismatch that we can have, or hemolytic transfusion reaction, is what we call a delayed hemolytic transfusion reaction. And this is caused usually by blood groups that have IgG antibodies. And so what happens is that somehow or other the recipient has been previously stimulated, their immune system has been previously stimulated, either by prior transfusion or, if it's a female, by a pregnancy. Don't have to give birth, just a pregnancy. So that can stimulate the immune system, and then the titer of that blood group antibody falls way, way down so that it's below detectable levels. Then, because our transfusion laboratory has not been able to detect any atypical antibodies, that person may be given blood that has that corresponding antigen on it. And then the immune system recognises that, and then the titer of that antibody rises, but that can take up to 7 days. And so we get what we call a delayed hemolytic transfusion reaction. Because it is IgG class, we tend to get extravascular hemolysis, and it doesn't tend to be as severe. Okay, you'll learn a lot more about this next semester. With hemolytic disease of the fetus or newborn, we get what we call a transplacental bleed. And so just to remind you about the fetus in utero, so here we have the fetus encased in amniotic fluid in the amniotic sac within the placenta. And this area here is known as the chorionic villi, and this is where we get interchange between the fetal blood circulation and the maternal blood circulation. And so these villi are very similar to the villi that we have in our digestive tract, and they have a very similar purpose to the villi in the digestive tract. And they're also very similar to the alveolar sacs that we have in our lungs. Okay, so they are responsible for the crossover of gases between fetus and mother. They are also responsible for the crossover of nutrients and metabolites between the fetus and the mother. But this is the maternal blood here, this is the fetal blood within the blood vessels. They don't actually meet. So there is a semi-permeable membrane, and so everything diffuses through that membrane. Very occasionally, most often at birth, but sometimes it can happen during the pregnancy as well, we can get rupture of these chorionic villi, and we can actually get fetal blood entering the maternal circulation. So we have fetal, that's what we call a transplacental bleed. When the fetal blood enters the maternal circulation, if that fetus has antigens on its red cells that are different to the mother's, because remember, the fetus gets half of its genes from the mother, half of its genes from the father. If the father has an antigen that the mother doesn't have, a red cell antigen the mother doesn't have, then the mother's immune system can produce an antibody to it. That antibody can then, if it is the correct class, can then cross the placenta into the baby's bloodstream and can attach to the fetal red cells, and then they can be removed by the fetal reticuloendothelial system. So we end up with a hemolytic anemia in the fetus. This results in congestive cardiac failure, which then results in what we call hydrops fetalis, which basically means a watery fetus. So what happens is that because the heart has been compromised, it can't pump the blood around the fetal system properly, so we have leakage, if you like, circulatory leakage of fluid into the spaces within the fetus, and so the fetus basically just fills up with fluid. If the baby is born, what happens is that with hemolytic anemia, of course, we get an increase in jaundice. increase in bilirubin. Once the fetus is born, becomes a neonate, no longer has access to the mother's liver to process that bilirubin for it, and so then we get what we call neonatal jaundice. And that can get really, really high due to all of the unconjugated bilirubin that's being formed from the hemolysis of the fetal cells. And because unconjugated bilirubin is fat soluble, it then dissolves into the fatty tissues of the body, including the brain. And so we can end up with brain disease, not brain disease, but so issues around brain development, and it ends up something that's called kernicterus. My brain has just gone to bed. Irreversible brain damage, that's what I'm trying to talk about, brain damage. So it's not a good thing, hemolytic disease of the fetus and newborn, best to be avoided if you can. So here are a couple of images for you to have a look at. So here we've got the normal neonate. So you do see, in a normal neonate, you do see some macrocytosis. That's quite normal. Can anybody tell me what this is here? This little inclusion? Tell the person next to you if you're not sure. That's a how jolly body. And we see that, so as you can see, this is a normal neonate, so you see that in a normal neonate. It just shows you that their spleen's a little bit immature. When babies are born, a lot of their organs are immature, particularly their liver, but also their spleen. You can see here that having a few nucleated red cells is quite normal, having a little bit of polychromasia is quite normal, having a little bit of spherocytosis is quite normal. But in hemolytic disease of the fetus and newborn, this is ramped right up. We've got lots of nucleated red cells there, we've got significant polychromasia and significant spherocytes. Okay, so that's the difference between them. So just before we finish, I'll just do this bit, if you can just hang on another 10 minutes, and then you can have a 10-minute break. So just to finish off with the immune hemolytic anemias, we've got drug-related ones as well. There are 4 main ways in which our drug-related ones work. And you can see here that the first one is what we call a drug-induced immune complex. And so this is what I like to call the innocent bystander mechanism. So, you know, the red cells are just minding their own business, thank you very much. A drug is injected into the body, and it absorbs onto the red cell. So it doesn't absorb, it coats the red cell, and then the body produces an antibody to the drug, but because the drugs are on the cells are lysed and destroyed. Okay, so it's not that the antibody is directed against the red cell, it's directed against the drug, but it just so happens that the drug is on the red cell. Okay? So that's what we call a drug-induced immune complex. So the second form here is the hapten mechanism, we call this. Can you remember from immunology, learning about a hapten mechanism? No nods at all? Raj will be very upset. So what happens is that sometimes an antigen is too small to be recognised by the immune system. And so to make it large enough for the immune system to recognise it, we can actually attach it to a larger carrier molecule. This is how a number of our vaccines work. And so what happens in the case here is that the drug is adsorbed onto the red cell. So you can see here that, well, it's got here that the antibody has actually complexed with the drug, but it's not until it actually gets onto the cell to a larger red cell, that the complement system is actually is activated. Because remember, the antibodies themselves don't actually lyse cells; they cause the cells to be lysed. Okay, so even when you're talking about bacteria entering the body or anything like that, the antibodies themselves don't cause cell lysis. They are part of the mechanism of cell lysis, often by the complement system or by phagocytosis from the reticuloendothelial system. And so then once it is large enough, once the drug antibody complex is large enough to be recognised, then it can be destroyed. And then the other two are what we call autoantibody mediated, where the drug actually stimulates autoantibodies against the red cell. So here we are thinking that our adaptive immune system is specific and wonderful, but we do have cross reactions within it, and so this is one of those cross reactions. And then the final one is, it's not actually an immunological etiology, but it does give us a positive direct antiglobulin test, which is so that's why we include it in this category, and that's where we get membrane modification. And so the membrane modification causes changes to the membrane which allow an increased absorption of IgG and complement and other proteins. And so that's why it results in a positive direct antiglobulin test, because you've also got IgG there, but it's actually due to membrane modification rather than antibody interaction, if you like. So there you go. So there's the way in which these, a summary of which the drugs work. So you can see here that a number of drugs can actually cause hemolysis, but there are other drugs that can cause the destruction of platelets and white cells as well. Usually the anemia is fairly benign. It's usually not that common. Although you can see here with quinidine and phenacetin, the immune complexes that it forms can actually cause kidney failure. So it's, they're not always benign, but usually they are. And we'll learn in transfusion next semester that the drug-related autoantibodies forming a positive direct antiglobulin test are a real pain, because the way in which you identify the antibodies that's causing the sensitisation or that's causing the immune reaction is you actually elute it off the red cell, so you can actually remove the antibody from the red cell, and then you can go and identify it. But if it's a drug-related one, then you're not going to be able to identify it. It won't identify as an antibody unless it's this one down here, one caused by Oldamet, which is an antihypertensive medication. It can mimic autoantibodies of the rhesus system, and you'll learn about that next semester as well. All right, so just finishing with our 29-year-old lady before you go and have a well-earned break. So we've decided that the provisional diagnosis, if we wanted to be really particular, would be a macrocytic anemia secondary to a hemolytic process. We can see that she's been transfused with 4 units of red cells and that it's 3 days later. So what do you think is causing this anemia? So Hansel's nailed it on the head, but he has done transfusion. So the fact that she has been transfused with 4 units of erythrocytes and it is her second child. So that gives us an indication that perhaps she has been previously stimulated and that her immune system has been stimulated, but the antibody that was formed, the titer has gone right down. But then one of these units of red cells, so when we're talking about a unit of cells, that means a pack, a blood pack. One of those packs of red cells contained the antigen that corresponded to the antibody that she had in her plasma. her titer rose because her immune system was stimulated again, and so once those antibodies were of a high enough concentration, they were able to sensitise her red cells and cause hemolysis. So we are looking here, as Hansel rightly said, at a delayed hemolytic transfusion reaction. And they are caused, so that is an immune hemolytic anemia caused by IgG antibodies. So that would be an allo antibody in this case. Okay? Does that make sense? So the further diagnostic test, what can you think would be the first thing that we would do if we think that this is an immune hemolytic anemia? The direct Coombs test or the direct antiglobulin test. Okay? Because remember that that is what detects sensitised red cells. Yeah? Any questions before we have a break? All right, so if you come back here by 2:10 on that clock, and we will continue. Okay. So just a quick recap. So far today we've learned that immune hemolytic anemias are caused by antibodies. So they're either antibodies directed against self that can either be warm or cold, and they can be 60% of cases they're idiopathic. That means the primary cause is unknown. 40% of cases they are secondary, and so they're secondary to some underlying disorder, often a lymphoproliferative disorder, but it can also be secondary to some sort of a bacterial or viral infection. Alloimmune hemolytic anemias involve antibodies that are directed against other, and they usually involve some sort of a blood grouping mismatch between either recipient and donor of a transfusion, or between the fetus and mother, as in hemolytic disease of the fetus and newborn. We can also have drug-related immune hemolytic anemias where by mechanism, 4 different mechanisms are responsible, and somehow or other there is an interaction between the drug, the immune system and erythrocytes, which results in the lysis of the red cells. And usually, one thing I didn't say, usually with these drug-related hemolytic anemias, usually what happens is once you withdraw the drug, the anemia clears up, as you would expect. So now we're going to go on and have a look at non-immune hemolytic anemias. And so these don't have anything to do with the immune system, so they don't have anything to do with antibodies. So they're often direct lysis of the cells by agents, or they are some sort of, something has changed within the environment that has caused lysis to the cells. So again, we're going to look at it through the eyes of a case study. And so this time we've got a 35-year-old woman. Now, if this lady was, say, 65 or 75 years old, complaining of weakness and forgetfulness, what other condition might you consider? Megaloblastic anemia or pernicious anemia. Yeah? Well done, everybody. So, again, well, that's what I'm saying. If she was 65 or 75. Okay, so again, you can see that by changing the population, you can change the causative agent, can't you? So that's why it's really, really important when you are looking at your case studies in the final prac exam to make sure that you look at all of the clinical information that's given to you, okay? Because they can be really, really strong indicators of what you should be looking for. In this case, it's a 35-year-old woman. Weakness and forgetfulness for the past 7 days. She has presented with a low-grade fever and bruising. So as soon as we see bruising, what are we thinking about? We're thinking about something wrong with the hemostatic system, something wrong with her hemostasis. Either her primary hemostasis, so her platelet count, or her secondary hemostasis, her coagulation system, or in fact her tertiary hemostasis, her fibrinolytic system. And so she said that she'd been otherwise well before the onset of the symptoms, and she's not taking any other drugs except for the oral contraceptive pill. So when you're learning about oral contraceptive pills, you may also see it written as OCP. So these were the FBE results from this patient. So we can see that she definitely has anemia, so that's quite a severe anemia. We can't tell whether or not it's a normocytic anemia, but we can probably tell from the fact that her symptoms have been for the past 7 days that it's not acute. That it's not chronic. That it is acute, okay? So if an acute anemia, that usually suggests that it's going to be a hemolytic anemia. No, it doesn't usually suggest it because we can have chronic hemolytic anemias. But when we're thinking, I guess, of whether or not it's going to be microcytic anemia or macrocytic, the hemolytic anemias are the ones where we get those acute occurrences. Okay? Have I clarified that for you? I haven't left you all confused. Okay, so we can guess that it's a hemolytic anemia because that's the topic that we're looking at. The other thing that will also suggest that it's a hemolytic anemia are these babies here. So we've got moderate polychromasia and we've also got moderate schistocytes. So what do those moderate schistocytes suggest to us? That it's intravascular. Yeah. So remember, schistocytes we see in intravascular hemolytic anemias or hemolysis. Doesn't have to be an anemia. Intravascular hemolysis will give you schistocytes, whereas if it's extravascular hemolysis, we tend to see spherocytes only. Okay? So we would be thinking some sort of an intravascular hemolysis is happening here. And our platelet count is 31, so that could explain the bruising. We've got a very low platelet count. And her coagulation results aren't all that, they're not that significant really. The PT and the APTT is slightly increased, her fibrinogen is slightly decreased, which means that it's probably been active, but it's probably not the major focus of her bruising here. It's more likely to be something to do with her platelets. Okay? Does that make sense to everybody? Okay, so again, keep this in mind as we're going through, particularly the platelet count, the blood film, and the coagulation results. So when we're looking at non-immune causes of hemolytic anemia, again, we've got a number of suspects. The first of these is abnormal plasma lipids. So there are two main ways in which we can result with abnormal plasma lipids in the body. The first is through chronic liver disease, and we've already looked at chronic liver disease when we were looking at our macrocytic anemias. And the other, of course, is lymphoproliferative disorders because of we can have hypergammaglobulinemia, which is caused by one of our lymphoproliferative disorders, that's multiple myeloma or plasma cell myeloma. So we'll be learning about those in the second half of semester. So these abnormal plasma lipids can cause hemolytic anemia because they produce more fragile red cells. Physical or mechanical trauma. So this is where we get one of our major forms of hemolytic anemia, which is microangiopathic hemolytic anemias, also known as MAHA, microangiopathic hemolytic anemias. If you have a look at this word, you can see micro meaning small, angio refers to blood vessels, and pathic means bad or condition of. Okay, so what is happening here is that something is happening in the small blood vessels of the body, so in the microvasculature of the body, which is resulting in hemolysis, in intravascular hemolysis of the red cells. And then we've got mechanical trauma to red cells within the vascular circulation. So this is a more direct trauma to the cells that we'll have a look at. Then we've got infectious agents, animal venoms, chemicals and drugs. So again, I don't expect you to know a lot about these conditions, but just enough to be able to differentiate them from each other and from other causes of hemolytic anemias and other causes of anemia. So we've already learned about chronic liver disease, but looking at it from a hemolytic perspective, you can see that the altered plasma lipids result in a shortened red cell lifespan. So here's another situation where we have a crossover between our categories of anemia. Okay, we've got a crossover here between our macrocytic anemias and our hemolytic anemias. And so we can see there that we also get alterations to white cells and platelets as well, because of course they have a phospholipid bilayer that is affected by cholesterol phospholipid ratio. So the other thing to note, of course, with chronic liver disease is that we do also get thrombocytopenia. And so, you know, our lady had thrombocytopenia, but she is only 35. And unless she started her liver disease in, you know, fairly early on, it's unlikely that it's going to be chronic liver disease that's causing this. And also we decided that it probably wasn't a chronic condition, it was more likely to be an acute condition. Yeah? Okay, so again, just to remind you about how we can get these changes to cell shape with our abnormal plasma lipids. So depending on whether or not we get deposition or changes to the shape of the cell depends on whether or not it's the external part of the lipid bilayer that's affected or the internal part of the lipid bilayer that's affected. And so we do get more, in liver disease, we get more target cells and stomatocytes unless it is in the end-stage liver disease, end-stage chronic liver disease, which is when we get our spur cell anemia. You may remember that term. We talked about spur cell anemia when we were talking about liver disease. So the next subdivision on our list was physical or mechanical trauma, and this is where our microangiopathic hemolytic anemias and our mechanical trauma to red cells comes in. So you can see there are 4 main forms of microangiopathic hemolytic anemia. And again, the main thing that I want you to know is the differences between them. So whether it be the population at risk, whether it be the FBE results, whether it be the further diagnostic tests. So that's why I've put them on a slide like this, which is a lot of information, but I think it just helps you to compare and contrast when you do things like this. So we can see that TTP we have already looked at in Haematology 1. So you may remember when we were learning about coagulation and the ADAM TS13 enzyme. Do you remember that? And how it is responsible for cleaving our long von Willebrand multimers into much shorter lengths. And you may also recall from Haematology 1 that the von Willebrand factor is required to help to tether platelets to the cell wall, so to the collagen that is exposed when we get damage to the blood vessel wall. And it can also help to form bridges between platelets. So it is very much involved with primary hemostasis, with platelet activation. And so when we have an absence of this enzyme, and it can be either inherited or acquired absence, then we don't get the cleaving of the von Willebrand's multimers, and so we tend to get spontaneous activation of platelets because these large multimers are able to interact with the platelets far more easily. So we can get sort of strips of von Willebrand factor with a number of platelets attached to it. And so what ends up happening is that we get thrombi in our microcirculation. So remember, this is microangiopathic. And so the platelets are activated, and so we get these little clumps of platelets in our microcirculation. We get fibrin strands between the platelet clumps, because remember, that's part of this primary, part of hemostasis, isn't it? So we get some activation of the coagulation system, enough to get our fibrin strands. And so what happens is, as the blood, as the erythrocytes come through these microvasculature, they actually get broken up. They get fragmented when they're being pushed past these occlusions in the blood vessels. Okay, so we get fragmentation and and lysis of the erythrocytes. And so we get a hemolytic anemia, we get schistocytes and spherocytes because we've got intravascular hemolysis in these microvasculature, and we also get a decreased platelet count because the platelets are being activated. But you can see that the coagulation profile is fairly unremarkable. So it's all about primary hemostasis, it's all about activation of platelets. The other thing to notice here is that it is mainly seen in adults and it's more likely seen in women than men. And the acquired forms of this condition due to infection, so a lot of infections will actually trigger off our hemostatic system, as we learned last semester. Drugs, connective tissue disease, so anything that's exposing collagen, neoplasms and pregnancy. Hemolytic uremic syndrome, on the other hand, is almost exclusively seen in quite young children. And traditionally, when it was, or classically, when it was first described, the causative agent was Shigella dysenteria type 1. So it's a toxin that is produced by this bacterium that is able to trigger the primary hemostasis. These days, infection with Shigella dysenteria is quite rare, and so normally when we see hemolytic uremic syndrome, it's caused by a particular strain of E. coli which produces what we call a Shiga toxin. So it's a toxin that's similar to the one that the Shigella dysenteria produces, but it's a strain of E. coli. And you can see here that it presents as an acute kidney injury. So while TTP can affect various organs, the kidney being one of them, HUS, hemolytic uremic syndrome, presents as an acute kidney injury. So you tend to get abdominal pain or flank pain and bloody diarrhoea in young children. You get a severe intravascular hemolysis. So in both cases, because it's intravascular hemolysis, we have markedly reduced haptoglobin. They're not immune anemias, so the direct antiglobulin test is negative. They have similar FBE results and blood pictures. They have similar coagulation profiles and platelet counts, but the big difference between them is the age. And also probably the fact that, you know, this tends to present as a diarrhoea. As you can see, it's plus or minus, whereas this has different symptoms, so certainly not this. Okay, so that's the big difference between them. So again, they both have spherocytes, they both have schistocytes, even though this one doesn't show us very many schistocytes there. Disseminated intravascular coagulation, so this is from Hematology 1. So again, you can see that it causes a microangiopathic hemolytic anemia. The main difference between DIC and the other forms of microangiopathic hemolytic anemia is the fact that we get consumption of the coagulation factors. So in the other conditions, we tend to get thrombocytopenia, but the coagulation profile is fairly normal. Having said that, with some forms of hemolytic uremic syndrome, you can get abnormal coagulation that looks a little bit like DIC, but again, it's this clinical presentation and the population that's being affected that gives you the difference. So you can see here, commonly caused by septicemia, neoplasms, tissue, vascular injury, pregnancy complications. There's a lot about pregnancy. And again, we just get this uncontrolled formation and lysis of fibrin. So this is more, and end up with fibrin deposited within blood vessels, just like the other microangiopathic hemolytic anemias. But the main difference is that we get the whole of the hemostatic system is being activated here, not just primary hemostasis. And so we tend to get abnormal coagulation. So similar to the other microangiopathic hemolytic anemias, we have schistocytes and thrombocytopenia, but we have highly abnormal coagulation. And then the fourth of our primary microangiopathic hemolytic anemias is a condition called HELP. And that stands for hemolytic anemia, elevated liver enzymes and low platelet count. So the thing that differentiates this condition from the other microangiopathic hemolytic anemias is the liver enzymes. Okay, so you get a similar picture except that you have liver damage. The hemolysis and the thrombocytopenia tends to be less severe, but we have liver damage as well. So that's the main difference there. And again, normal coagulation until very late in the disease. Now this is a complication of pregnancy. And again, it's a very specific population that is affected. Just have to catch up with myself here. I thought there was something else I wanted to say about that. So this usually develops prior to childbirth, often in the third trimester, and it's thought that it is that it might be associated with preeclampsia or eclampsia. So it could be sort of a complication of preeclampsia or eclampsia. But it is induced because we get the hypertension, which we see in preeclampsia, and we also get disseminated intravascular coagulation. They don't know why it happens, it just does. So if we come back and have a look at our lady, she's got her bruising, she's on the contraceptive pill, she's got schistocytes and polychromasia, but she's got fairly normal coagulation results. So her age and really precludes hemolytic uremic syndrome. She's not pregnant, so that precludes the HELP syndrome. She's got fairly normal coagulation results, so that precludes disseminated intravascular coagulation. So we're really looking at either TTP or whichever other one I said before. No, it really is only TTP. I think we've managed to rule out everything else. Okay? So thrombotic thrombocytopenic purpura. So purpura is another name for bruising. And so we can see here that her symptoms worsened over the next few days. And so she ended up with getting kidney involvement here, as well as brain involvement, if you like. So there's a number of organs in her body that are also being affected, which is, again, something that is very common with TTP. And so thrombotic thrombocytic purpura, single episode. So what do you think might have caused this? How many of you have ever taken the oral contraceptive pill? When you went to your medical practitioner to get a script for the pill, were you asked if there was any history of thrombosis in your family? So the oral contraceptive pill, one of the side effects of the oral contraceptive pill is an increased risk of thrombotic conditions. And so that's probably what's happened with this lady. All right, so has anybody got any questions about microangiopathic hemolytic anemias, apart from how to pronounce it? Is everybody's brains full and exploding? The hemolytic anemias tend to do that to you because they're just so huge. So this is the final little bit, and this bit is fairly straightforward. So this is anybody a marathon runner or does really prolonged sort of high impact exercise sessions at all? No, yeah, got some. Anybody noticed after these sessions that they pee blood? No? Okay, so you're obviously more resistant. So this is what is caused when we, this is exercise-induced hemoglobinuria, and is also, you will see it called March hemoglobinuria, because the first time it was described was by physicians looking after Roman soldiers. And of course Roman soldiers used to march for miles and miles and miles and miles and miles. And they noticed that they peed red blood at the end of the day, and that could last for several hours, or their urine was red. And this can also happen with people who do high impact exercise, particularly any exercise that means sort of banging against a hard surface, such as running. So it is quite common to people who are marathon runners, but it also can be seen in people who do prolonged training sessions for swimming or for rowing or any other sport where you do playing tennis, for example, cycling. And so they're thinking, they're not really sure what happens here, but they think that it could be that it's when the erythrocytes are in the microvasculature, so in your veins, and basically, but it could be due to increased oxidative stress rather than the actual physical pounding, because we don't get schistocytes in this condition. And we call it exercise-induced hemoglobinuria because you don't get an anemia with it. All that you see, so the main thing with this is that you just see hemoglobin in your urine. You get that red-brown colour to your urine, and that can happen directly after exercise, and it can last for several hours. So it just seems to be that at certain times, with exercise, that the red cells become more fragile, and they lyse rather than being shattered by, being pushed past something hard. So it is transient, so it's associated with that physical movement. It's intravascular. Not really, no. But, if you pee blood, then usually you want to know why you're peeing blood, and it's probably a good idea to go to the doctor to find out. But this is a more benign condition, yeah, and it's really all that you see. But it is a cause of hemolysis, hence why we're looking at it here. So, if you ever have anything to do with the Australian Institute of Sport, for example, or, you get to be in a lab where there's lots of testing of athletes, you may see this. Okay, so with thermal injury, so this is an actual direct effect of heat on the blood. So, if you raise the temperature high enough, you will lyse blood cells. So burns are just the most horrendous thing, and they do a lot of tissue damage, and they also affect your blood cells as well. There's a direct effect on the blood cells, so not just your tissue cells. And so what we can get here is a lysing of the cell membrane, so you can get protein denaturation, because of course that's what heat does, and it can, of the proteins in the red cell membrane, so they can actually affect the red cell membranes. And we also get altered metabolism of the fatty acids and lipoproteins that are in the red cell membranes as well. So we get this really abnormal red cell morphology, and they call it red cell budding. So not only do you get schistocytes and spherocytes, but you get these little buds of erythrocytes here. And that's just because, the membranes have just been affected by the heat. On the right-hand side here, you can see the results of traumatic cardiac hemolytic anemia. And so what's happening here is that it's not that common these days, but certainly when I first went into the lab, we used to see this a fair bit. So it's to do with when people have had a prosthetic heart valve surgery, so they've had some sort of abnormality to their own heart valves or some sort of damage due to disease, and so they have them replaced. And so it is these replaced heart valves which actually, what they do is they affect the flow of the blood, so it's all to do with the physical properties of laminar flow of fluids, and so you get more turbulence, and so you end up with the red cells being slammed into the mainly plastic and sometimes metal parts of these valves and just literally being smashed to pieces. And so you get a lot of schistocytes in this condition. So if we go back and have a look here, we can see that in this case the platelet count is not significantly decreased, so unlike the microangiopathic hemolytic anemias, our platelet count is usually normal. You do get significant fragmentation and intravascular and extravascular hemolysis as well. And then just finally we have our infectious agents, so we can have direct parasitisation of erythrocytes, and we'll be looking at that tomorrow. In the tutorial we'll be having a look at malaria. The reason that we're focusing on malaria is because it still causes significant mortality and morbidity in the world today, particularly in the developing world, but also of course through Asia and through the Middle East as well. So we'll be having a look at malaria tomorrow. Bacterial hemolytic toxins, particularly from Clostridium species, are able to directly hemolyse red cells. And then we've got our animal venoms. So animal venom such as snake venom doesn't directly hemolyse red cells, but it does cause thrombosis and DIC, and therefore a microangiopathic hemolytic anemia. And then spider venom, bee stings, wasps, scorpions, they actually do membrane damage. So they damage the red cell membrane, causing intravascular hemolysis. Then there's a number of chemicals and drugs that are on a list that's going to come up in a minute, and these can cause hemolysis due to membrane damage, or they can cause hemoglobin denaturation, and then we get our drug-induced Heinz bodies. So then we get our bite cells that we see. Remember when we had a look at G6PD deficiency, the bite cells that we got there. And then we have lead poisoning, which can lead to a form of sideroblastic anemia. And do you remember the term punctate basophilia? So we came across that term when we were talking about sideroblastic anemia and also our thalassemias, and we get punctate basophilia with lead poisoning. So that's just a reminder about sideroblastic anemia from earlier in the semester. So the difference with lead poisoning is we don't tend to get this dimorphic blood picture, but we still do get, it still does interrupt the heme synthesis, the same as what happens in sideroblastic anemia, and we still do get the ring sideroblasts in the bone marrow. But what we see on our blood film is more this sort of a thing. So you can see that the cells are fairly small, but we get, this is what we call punctate basophilia. So the basophilia is quite, the dots are quite large. You probably don't remember, but in beta thalassemia you get quite a fine basophilia. But here with lead poisoning, it's much more, it's like someone's sort of come along and punched the cell. So here's our infectious agents that we'll be having a look at tomorrow. So this is Plasmodium species, a couple of different forms of Plasmodium species that you're going to be able to identify in the laboratory, you'll be pleased to know. And this is Babesia, which is very common in the United States. So there you go. As promised, there's a summary of non-immune extrinsic hemolytic anemias and their mode of hemolysis. Very, very important for the hemolytic anemias is the populations most at risk. And so you can differentiate a number of them by the population that's being affected. Some review questions for you, and so now you can leave and give your brains a rest. Anyone got any questions?